بسم الله الرحمن الرحيم. Non-specific interstitial pneumonia. The definition of non-specific interstitial pneumonia. The term non-specific interstitial pneumonia (NSIP) is the description of a histological pattern rather than a specific clinical entity. The form of interstitial pneumonia or this form of interstitial pneumonia is particularly poorly understood, and the histological pattern of non-specific interstitial pneumonia properly encompasses several distinct clinical and radiological conditions. Indeed, a proposed subclassification divides non-specific interstitial pneumonia into three clinical radiological clinico-radiological syndromes. The clinical utility of this subclassification is uncertain and include the following: non-specific interstitial pneumonia with an IPF-like profile and overlap, as to say, non-specific interstitial pneumonia over IPF. The second syndrome include non-specific interstitial pneumonia with an organizing pneumonia profile. That say non-specific interstitial pneumonia over organizing pneumonia OP. And the third syndrome is non-specific interstitial pneumonia with a hypersensitivity profile. That is to say, non-specific interstitial pneumonia over HP, which is hypersensitivity pneumonitis. Patients with non-specific interstitial pneumonia on lung biopsy have a generally better prognosis and a greater response to steroids when compared with patients with IPF. Non-specific interstitial pneumonia may be idiopathic or occur in association with other systemic conditions, most notably connective tissue disease. Epidemiology. Typically, unspecific interstitial pneumonia typically affected typically affects younger patients than IPF, with age of onset ranges from 40 to 50 years and may rarely affect children. Causes and associations of non-specific interstitial pneumonia include the following: idiopathic, connective tissue disease. Non-specific interstitial pneumonia may be the first manifestation of the disease. The drugs, infection, and immunodeficiency problems such as HIV, post bone marrow transplant, and chemotherapy. Clinical features of or clinical picture of non-specific interstitial pneumonia. There are few specific clinical features that help distinguish non-specific interstitial pneumonia from other interstitial pneumonias. Described features include breathlessness, cough, weight loss, and the onset is gradual or subacute. A typical symptom duration before the diagnosis varies half to 3 years. Crackles at the lung bases, later more extensive, clubbing in a small proportion of patients. Investigations. HRCT frequently shows GG changes or ground glass change, often in a basal distribution with or without reticulation and traction bronchiectasis. The appearance is usually more confluent and homogeneous than the patchy heterogeneous distribution seen in IBF, and the honeycombing is usually absent, occasionally seen in fibrotic, nonspecific interstitial pneumonia. PFTs or probability function tests typically restrictive pattern but impaired gas transfer in only 50%, and the saturation and exertion is common. The bronchoalveolar lavage can reveal lymphocytosis in common situations. Lung biopsy is often required. Investigations to exclude underlying disease should be done, such as rheumatoid factors or immunological antibodies. Histology. Ranging variable histology of non-specific interstitial pneumonia is variable, ranging from a predominantly cellular pattern, mild to moderate interstitial inflammation, and no fibrosis, to a fibrotic pattern in which there is interstitial fibrosis or homogeneous appearance than an unusual pneumonia UIP and lack of fibroblastic foci or honeycombing, and lung architecture may be relatively preserved. Non-specific interstitial pneumonia may be subclassified based on the relative proportions of inflammation and fibrosis. Non-specific interstitial pneumonia, one in which primarily inflammation, termed cellular. Non-specific interstitial pneumonia include inflammation and fibrosis, and non-specific interstitial pneumonia 3, in which there is primary fibrosis. Features of both the specific interstitial pneumonia and the usual interstitial pneumonia are sometimes seen on biopsies from the same individual. In such cases, the diagnosis is considered to be IPF, indicating a poor prognosis. Diagnosis. Clinical and HRCT features are not specific, and surgical lung biopsy is often required for diagnosis. An exception is non-specific interstitial pneumonia in the setting of connective tissue disease, when histological confirmation is not usually required. Biopsy evidence of non-specific interstitial pneumonia should be interpreted in the context of clinical and radiological findings, using a multidisciplinary approach in order to assign to the best fit in non-specific interstitial pneumonia syndrome, including non-specific interstitial pneumonia and IBF, non-specific interstitial pneumonia and organizing pneumonia, or non-specific interstitial pneumonia and hypersensitivity pneumonitis. The management. Treatment with corticosteroids with a typical prednisolone dose of half mg per kg, and bone protection is recommended in patients while on high dose corticosteroids. Consider PPI and cotrimoxazole prophylaxis, 960 mg 3 times a week against PCB. As with interstitial pulmonary fibrosis, disease progression and response to treatment are best assessed by serial measurements of FVC and TLCO with absolute changes of 10 to 50% or more considered significant. Additional immunosuppressive treatment is usually azathioprine or mycophenolate mofetil are used in patients who fail to respond to corticosteroids alone. Prognosis variable. Most patients improve or remain stable on treatment. Cellular pattern of biopsy is associated with a good prognosis. Fibrotic nonspecific interstitial pneumonia is associated with a markedly better prognosis than IBF. 5 year survival more than 50% in fibrotic nonspecific interstitial pneumonia compared with 10 to 50% in IPF. That's all, and thanks.